Okay, welcome everyone. Thanks for attending the Colorado League of Women Voters Healthcare Task Force this evening. I'm very excited to welcome members of the Vermont League of Women Voters who are going to explain their effort to update the League of Women Voters national position on privatization in healthcare, which dovetails very well with the work we've all been doing regarding single payer or Medicare for all. And today down at the Capitol was, I forget the exact title, please forgive me, but it was Healthcare Day. So I hope some of these folks are in this meeting. Because I'm on my phone, I can't see everybody who's here, but I hope Virginia's here. Maybe she can give us a little synopsis of how the day went. But in the meantime, let's get started with our presentation. We have two presenters here tonight from Vermont. Betty Keller is a retired family physician on the League of Women Voters in Vermont's State Healthcare Committee and is here to speak with us about the position on privatization that the Vermont League recently passed and why they would like to use this position to update the national position on privatization in healthcare, how local and state leagues can help get this on the agenda for the national convention, and what if it would allow the leagues to do. She's also the president of the Vermont chapter of Physicians for a National Health Program, which is PNHP. Her colleague, Eduardo Sequeiro, is a public health physician who recently moved to Vermont after retiring from the faculty at the University of Massachusetts in Boston. He is a longtime member of the American Public Health Association, as well as a member of the Physicians for a National Health Program. Eduardo is now new to the league, and so he will be primarily assisting and answering questions related to the issues of privatization. Betty will address questions related to league process and policy while welcoming assistance from more experienced members of the audience. So welcome, Betty. Thank you so much also for staying up kind of late, in Vermont.
Well, it's not late yet, but it will be by the time we finish. So
that's what I'm thinking. So go right ahead.
Well, thank you so much for inviting me and for your time and attention as I speak today with you about the League of Women Voters of Vermont's privatization position. And it is, it's more complicated than it seems like it needs to be, but I'm going to just start off at the beginning with saying that although our motivator was healthcare, the position is actually a privatization position. And the bulk of our position is about the privatization of healthcare. But there's a couple little snippets in there to make it be expandable to other things as well. But I did want to explain that right from the start, because that's been very confusing to some people. And so I'd like to just start off explaining that Vermont is a small state. We have about 130 members. They're all at large. We have no local leagues. So when I say I can appreciate help from the audience on process, I mean it, because we are not familiar with some of those details between local and state leagues. So if I misstate something, please jump in and correct me so we don't have people misunderstanding. And I appreciate your assistance on that. So since we are so small, this was an enormous project for us, but we were passionate about it. Vermont League members and their elected officials have had a history of advocacy for single-payer health care, and League of Women Voters of Vermont has typically received approval when we've sent in federal action request forms. Now, I may refer to those as FARFs later. Those are a league piece of paper that you fill out when you're communicating with the national office about federal actions, meaning wanting to reach out to your member of Congress, wanting to reach out to the president, wanting to reach out to one of the secretaries or something. So anything in the federal government. And so when we, and so they're used to us asking them to do things like, can we reach out to Bernie Sanders and ask him to reintroduce his bill or hold a hearing on Medicare or something? They usually have just said yes. So in the fall of 2022, we were really concerned that folks who specifically signed up for traditional Medicare and paid extra in supplemental insurance premiums to be sure they had no networks and that they were well protected if they got really sick. And they were now being shunted into for-profit accountable care organizations without their prior knowledge or consent. Not all of them, but these innovation models were being developed, and they were getting sent in without advance notice or getting their permission. They were basically told, if you don't want to be, they got a letter telling them, you are in this, if you want out, you'll need to change doctors, which is easier said than done in many cases. So this all was through the innovation programs created by the Centers for Medicaid and Medicare Services Innovation Center, which was created out of the Affordable Care Act. So I'm going to go ahead and start sharing my screen, if I may.
Mm-hmm.
And I'll get that going in
There we go.
mode. There we go. Okay. So, so these new for-profit entities were called DCEs first, and they got enough stink that they changed their name, but they're kind of the same thing. ACO Reach, Accountable Care Organizations, Realizing Equity, Accountability, and Community Health, or something like that. Something to make it sound better than DCEs. And so these ACO Reach organizations would create incentives for doctors to avoid expensive care for their patients. It would add a layer of bureaucracy that reduces access to care for patients, increases the administrative and moral burden on clinicians, and uses predatory tactics to receive overpayments that will drain our Medicare trust fund more quickly than traditional Medicare would. So we didn't want to just educate about these. We wanted to advocate against them. We figured that the League was a longtime supporter of Medicare, so of course they would be on board with protecting Medicare and Medicare beneficiaries. We filled out our federal action request form. See if I can get that. There we go. So if you're just educating, you don't need to fill one of these out. But if you want to actually advocate, then you need to fill out one of these federal action request forms. You need to say what is the national position on which you're basing it. And you need to make sure that your state board is also on it. So on board with you taking this action, because they don't want any conflict between what different levels are trying to do. So, but the things we wanted to do were to ask League members to write to members of Congress and to Secretary Becerra and President Biden. So basically, if you need to change a law, you write to members of Congress, but you didn't actually need to change a law for this. Trump got it started based on the ACA, and President Biden has let it continue, and Secretary Becerra could just say, yeah, we're not going to do this anymore. So we don't actually need to pass a law for this. In addition, we wanted to ask League members to write letters to the editor, educating and urging the public to also take action. And we wanted to, we weren't sure we were going to do this, but we wanted to put it on the request form in case we decided to do this, was to seek a state resolution from our state legislature opposing the ACO Reach program. And we wanted to ask members of Congress to co-sponsor legislation to protect and improve Medicare. So we were expecting an easy yes on this, and we got a no. So, so the first thing was, well, they told us that the LWV advocacy team told us that the healthcare position wasn't the right position to use. So the healthcare position is in the social policy section on page 137, and that is where we added that concurrence 2 years ago at the convention in 2022, when New York did a big study and wrote a large piece, and that got added to the healthcare position. And we thought we were totally covered with our request with what had been put in the healthcare position and what was already there. And they said, well, no, it's not actually a health policy question. But the appropriate position for our advocacy was the privatization position, but that position didn't support our requests. So there was no position to support the actions we wanted to take. Well, how is this not a health policy question? So the thing is that the concerns we raised were less about healthcare policy, what goods and services patients get, what providers can expect, and what taxpayers pay for. Our concerns were more about control over resources, management, and distribution. So the ownership structures and the business models. And we were also very concerned that the things we defined as public goods, like healthcare, should not be considered commodities subject to a free market. So the the LWV advocacy team referred us to the privatization section found in the representative government section of impact on issues. It's actually earlier in the impact on issues, page 67, because making democracy works, it comes before the social things, and the representative government section came in there. So there you'll see a list of public goods that are offered special protection, allowing league members to advocate for those. And healthcare is not specified on that list. So the first sentence is about, excuse me, or maybe somewhere early in the position, privatization is not appropriate when the provision of services by the government is necessary to preserve the common good, to protect national or local security, or to meet the needs of the most vulnerable members of society. So, well, we kind of thought that healthcare is important for the common good, and it's important for meeting the needs of the most vulnerable members of our society, but that wasn't specific enough, I guess. And so, and another concern, and let me see here. So then it goes on to list that services fundamental to the governance of their democratic society should not be privatized in their entirety. These services include the electoral process, justice system, military, public safety, public health, education, transportation, environmental protection, and programs that provide, protect and provide basic human needs. But it doesn't actually specify healthcare on there. Now, if you look at the basic human needs section of the impact on issues, healthcare is listed there, but it wasn't specifically listed in here. So we were not allowed to use that as our basis. But there was a second reason too. Let me see here. I wasn't expecting that slide quite yet. So privatization, in the position has a specific set of criteria that you're supposed to meet in order to take something from the public sector and put it in the private sector if it's a public good. And these are all very carefully laid out in a couple sets of bullet points. But in 2012, when they wrote this up, they didn't actually address what to do or provide an opportunity to advocate for bringing them back if those criteria were met initially and then they no longer were met, or if those criteria were never actually dealt with and the public goods were just turned over to the private sector anyway. So that was not addressed in the privatization position. It only talked about the movement of goods and services of public goods from the public sector to the private sector. So unfortunately, the league positions we create are not the law and they're not legally enforced. So privatization and profiteering have been happening anyway without those criteria being met. And so now what do we do about that? Medicare Advantage by this time was making its way into news cycle and not in a good way. This is a PNHP report about the overpayments to Medicare. And here you can see that a while ago, most of their overpayments were because they favorably selected by just putting ads in the, on bulletin boards and health, fitness centers and things. And then over time, they figured out how to do enough gaming that they're like, oh, we don't even mind if we get sick people. We can both get favorable selection overpayments, and we can also do coding intensity overpayments and make our patients look sicker than they are and get extra money that way. So we're actually paying them over that time period. We had paid them $547.4 billion more than we should have been. So in 1 year, it is 140 billion. See all those zeros? It's not million. I mistakenly said million earlier on another presentation. $1 billion per year. And what would you do with that instead if you didn't overpay? Now you can see the Part B premiums are this 131 green block. And that is for the Part B premiums that everybody has to pay whether they go on the Medicare Advantage plans or whether they stay on traditional, they have to pay Part B. Just the people who do the traditional don't have super good coverage because there's no cap on how much you might pay out of pocket in a year, and because you have 20% copayment. Now, that was actually written in 1965. It was planned to make sure that the insurance companies got their business still. They still got some business. And so there was just anticipated that people would have to buy another plan, and those have gotten more and more expensive over time. And um, it's quite challenging for people on a tight budget. So there's a big motivation for them to go to these Medicare Advantage plans, because with Medicare Advantage plans, there's typically low or no premiums because they can charge so much for overpayments. It's an incentive to get you into their plan and do that overcharging. And they also can afford, the Medicare Advantage plans can afford to provide the dental, hearing, and vision on their ads, although it's not always actually accessible because of their narrow networks and the distance to get to the ones that are on the network. And because there are things written into law that actually make it easier for Medicare Advantage to do that, whereas traditional Medicare is not in the law to be able to provide that. So a couple things you could do with $140 billion per year is you could create a cap for only 39. And that would still give you more money that you could pay for some of the dental or hearing or vision, or you could lower the premiums so that it would be easier on folks with low incomes. So it's somewhere between 88 billion and 140 billion, somewhere in between those two. But definitely well over what it would take to create that out-of-pocket maximum, so that people would not need to buy the supplement to have healthcare security. So at this point, we had to figure out, well, even if we created a position, then we still wouldn't be able to do this stuff at the federal, regarding federal programs. So what kind of a scope would we want to do? So we looked at the same time, there was a lot of stuff going on in the news about privatization, private equity closing a hospital and selling the real estate underneath it. After they bought one in Philadelphia, the hospice movement becoming a for-profit hustle, corporate investors investing in primary care so they can direct care toward their own specialists that they also hire and toward the pharmacy products that they also sell. This is about private equity buying oncology clinics. So there's a bunch of different things that were in the news that were catching our attention. So we decided that our goals were to see whether there is justification for writing a position that could do the things that we thought we wanted to do. Protecting clinics and hospitals from getting sucked into bad deals that destroy our healthcare infrastructure. Protecting patients from delayed and denied care, from understaffing, and from financial disaster. Protect healthcare staff from being forced into contracts that can cause moral injury. Protect Medicare from further privatization, and improve Medicare, getting rid of privatization and potentially using the savings to pay for an out-of-pocket cap and reducing premiums on Part B. Now, here's the thing is that actually I could have written it the other way around. If we improve Medicare and if we improve Medicare by creating the cap and reducing the premiums on Part B, that would drive enough people off of Medicare Advantage, because they would no longer have those concerns, that you wouldn't have to create a law to get rid of privatization. You could just make it less favorable with all the overpayments. So the other thing that we wanted to do is that we wanted to provide the grounds for the LWV US staff and for league members across the country to advocate for healthcare as the public good and for deprivatization of public goods where appropriate. So the League of Women Voters staff will only act on national positions, and they will only act on them when it is a priority. So we had two problems, and we were doing one study. So the first scope was to examine and evaluate the various ways that healthcare fits the criteria to be included as a public good as defined in our position. And the second was to examine and evaluate whether the position should be expanded to include the other direction as well, movement of services that are public goods from the private sector to the public sector. So this is the website for our Vermont position, and at the end I'll show you where to find these things on the website when I screen share. And this is for the toolkit at the Legalman Voters Healthcarereform.org site. And they will be where the bulk of our stuff will be posted, because we're a small league. We don't have anybody who is skilled with enough time to do frequent posting for us to update things. If you see a mistake, fixing it, that sort of thing. So we're really leaning on this other interest group within the Legalman Voters, with people from across the country who help to keep that updated for us. So I understand that you all got the the Vermont position or the concurrence, which they're the same, except one says of Vermont in some places and the other one doesn't. So they're basically the same. So I'm thinking that we don't need to go through it in too much detail. Let me just, as I skip over that part to where it'd be a summary instead of reading it here. Okay, so the Vermont position starts off with declaring that healthcare is a public good. We go on to say that public funding, oversight, and delivery are essential to optimize equity and access, and that we need quality, transparency, accountability, and affordability for effective administration. We also believe that healthcare can't follow free market principles, and so a private enterprise for-profit business model can't work in healthcare. And in our report, we'll go into more detail writing that up, and we have some examples written right into our position that are the ones that stand out the most, but that will be described more in the report. In addition, the league let me see here. That's another free market principle. We'll scoot through those. Okay. So the league feels that healthcare is a good for fiscal reasons, as the most fiscally responsible way to provide healthcare accessible to all individuals and families. So we want to make it clear that when private entities fail to deliver on the criteria in the current LWV position, those criteria are all listed out there, that we can advocate for deprivatization. Now, I want you to look at the yellow parts, and those are the parts that help this position apply to other places outside of healthcare. You know, our focus, the bulk of our study was on that, but some of the books that we read were talking about privatization in general. And certainly we're seeing that in the news as well. I had been to a couple of conferences where I was asked to talk about privatization in healthcare, and there were people from the Postal Service and from the VA, which is also healthcare, but a different sector that most of us aren't eligible for. So, so those are the parts that can be helpful for other advocacy. So we're going to talk a little bit about national positions. So all league members can use national positions if they go through the right steps, and if their actions do not conflict with any other league positions or values. As you just heard me describing the same issue, we're trying to figure out, well, does it fit under healthcare, privatization, or basic human needs? So sometimes you might have to look across a few different policies to make sure, a few different positions to make sure you don't have any conflicts. Local leagues can freely advocate at the local level, and state leagues can freely act at the state level with a national position. Local leagues need to get permission from and coordinate with both the state league and the national league to advocate at the national level. And they need to use that federal action request form, noting the national position on which your advocacy will be based. And I think as well that local leagues have to get permission from the state league before they can reach out to their state legislators. Is that right? Those of you from local leagues?
Say that again, Betty.
If you're a member of a local league and you want to write to your state legislator about a state issue, do you still have to make sure you can always write to them as an individual, but if you want to write on behalf of your local league, do you have to get permission from the state board first?
I don't know that you need permission, but you just have to be in alignment with Colorado's positions or whatever state you're living in.
You also need to let the state know so that you're all speaking with one voice.
There you go.
And that's the reason why you want to honor the levels in the league.
Thank you.
Mhm.
Okay, and as I had said earlier, that LWVUS does not advocate unless it's both supported by a national position and it's a priority. So even if we pass this, doesn't mean we've been asking them to advocate for single payer for a long time, and it's been supported by our position well before 2022. But it hasn't been a priority. Even in a pandemic, it was somehow not a priority. Making democracy work was also obviously a priority. But you have to have the position first, or they definitely won't. So the other thing is, if this does not become a national position, if we don't have enough delegates vote to concur, or if it doesn't even get on the agenda, then states and local leagues could choose to concur with it, and they could work at their own levels using it if they did choose to do that. But they would still not to be able to use this position for actions at the national level, of course. So information about the concurrence, we're probably going to be posting a chunk sometime in the middle of February, but again, pointing to the toolkit, because the toolkit is where we'll be able to keep things updated better. On the toolkit right now, that's at the lwvhealthcarereform.org website. We have the Green Mountain Citizen article, which is our newsletter in Vermont, our quarterly newsletter. We have the Vermont position, the privatization concurrence statement, which, as I said, is essentially the same, except you take out the words of Vermont, and instructions on how to include a request. The pros and cons are on there, but they're a little hard to find, and it's kind of a draft. I'm looking for people to send their ideas. We're finding that the pro positions are very easy to come to all of us. And the cons, we have a little bit more trouble drafting things that seem like, gosh, does anybody really believe that? So, and I mean, sometimes I read things in, what was it? The Journal of Value Based Care, or I forget, medical managed care or something. And I'm like, I don't have any idea whether that journal is even a respected journal. But anyway, so we would welcome your cons if you come up with good ones. The report is not ready yet, and as soon as it is, we will be posting that on the toolkit. We are collecting frequently asked questions, and a big one is privatization. Like, what do we mean by that? Does that mean nobody in private practice? Which is not what we mean. It's not what the league means by privatization either. And here is the picture of the homepage, and there's a red banner across the top, and I learn more. So I'm going to stop sharing. And I do want to spend a minute talking about privatization. So about what we mean by about not wanting privatization. So we're not talking about private practitioners, about psychologists or doctors or nurse practitioners or nutritionists. We're not talking about them not being able to be in private practice. That's not at all what we're talking about. So in some laws, there are these things called laws called corporate practice of medicine laws. And in those states that do them, sometimes they outlaw corporate practice of medicine at all levels. And by that, what their definition is that a doctor can own a practice, and a group practice can be owned by doctors, but that they cannot be bought or managed by private for-profit entities. And in some states, it's so strict that it can't even be a nonprofit hospital that owns them. That's not true in Vermont. A lot of doctors' offices are owned by the local nonprofit hospital, but that private hospital, but they're all nonprofits here. Now, there is a huge distinction between, like, what does nonprofit mean? Some nonprofits actually have lots of excess revenues that then can be invested somewhere else, and it's not actually getting turned back into the mission of the nonprofit. And so that may be an issue that people want to address too when they're talking about who can own portions of our healthcare system. But so corporatization is, people understand that more clearly as being for-profit corporations. But the fact is that nonprofits also incorporate, and even like a solo practitioner may have incorporated for business purposes, is how they do their taxes and stuff. So so that doesn't necessarily clear it up either. So I'd like to share now in my with my web page. Let's see if I can find the right window. Okay, so this is one of them. So this is the privatization position. So I'm going to start with that and just show you. So this is what I read aloud to you. And then down here are the bullet points. For these criteria should be met if you want to take something from public to private. That there needs to be ongoing communication between stakeholders and the public. Statement of what the circumstances are as they exist now and what's to be gained by transferring it. There's a bunch of really specific criteria that make a lot of sense. It's just that it also makes sense in the opposite direction. So that was one of our consensus, part of our consensus discussion was to actually look at these. And people are actually kind of annoyed that I was making them go through them all and say, does this one also apply in each direction? And they, for the most part they do, but the way they word it here, while specific criteria will vary by service and local conditions, the league believes the following conditions apply to most decisions to transfer public services, assets, and functions to the private sector. So that gives you some wiggle room if they don't all exactly match up for the particular service that you're looking at. So now I'd like to go to that toolkit. And for you to see the way it would look if you had just gotten there, I need to refresh. And now you have your banner. So here's the banner. And this is very handy because otherwise it'd be hard to navigate to it. You have to like go to the position and scroll through and come down to it. Because of course the healthcare position is talked about before you get to the privatization position. So you're going to click on the Learn How. And here is the Vermont Concurrence page. So this has a lot of the background we just talked about, like why did we do this and what are the questions that we were asking. And then there are some resources down here, a couple of, well, only one right now is written down, frequently asked questions. These are some resources, including the current privatization position for people to compare to, because it can be hard to find the impact on issues sometimes. And then these are some videos, including one that we had co-sponsored with the Physicians for National Health program back in February of 23. There's also a great one on private equity from New York Metro, PNHP. And down here is the address for where you can send questions or comments about the concurrence. And up here is a how to help button. So if you don't need to read all this other stuff because you've been to a meeting like this, or you've heard it elsewhere, you can just click that. And this shows the materials needed for the critical steps for how to get us on the agenda. So to get on the agenda, the national organization has to feel that there's enough people that care about it to justify that time from our meeting. It's only a couple of days. And so the more people they can say, oh, definitely want this, then the better that is for getting there. The problem is that they send out this survey, program planning survey, that the league presidents are typically the people who fill those out. And the survey is read by a computer. So if somebody calls it the healthcare privatization position, somebody else calls it the privatization position, somebody else calls it the position for deprivatizing. I mean, if you have it come in different ways, then it may not be caught as all being the same thing. And so we really want people to use consistent language. So on this list, here's the concurrence statement, so you can read it before you say that you want it on the agenda. Now, you're not necessarily agreeing that you want to vote for it. So one thing is, like, your board can approve that you do want it on the agenda, but your board can't tell delegates how they need to vote. They're supposed to study the issues and make a decision, and you're trusting them to represent you well. But they'll be there for the discussion as well, and they might change their mind. So this request is not requesting you to agree or approve of our position. It's to ask you to include it for discussion on the agenda. So this is the one pager is the explanation. Again, is some of the stuff that I just told you, and it has a couple of links on it. The instructions for how to support updating it are here. There's a PDF version and there's a Word version. And we'll go to the PDF version in just a minute. This sample message is really handy because it has links to like everything, rather than having to scoot back and forth on a couple of different pages and figure out, was that on the Vermont Concurrence page or on the How to Help page? Most of the stuff that's most necessary is on here. So I'll show you that. The yellow is the part, this is a sample message for sharing with other board members or with your planning committee members. So you take out the yellow things and put in what's appropriate for you. And you'll see, this is where you find that, the 2 pages from the impact on issues, the 1-page summary, the concurrence, the toolkit website, and the address for where to ask questions, and the oh, that's just the same thing, the address for where to ask questions. And let me see here. So now we're going to go to that how to support page. So the first ask is for you folks to talk within your planning group, planning committee, or your board about what do you want. Do you support it? Do you support the concept of putting it on the agenda? And if you do decide to do that and are willing to make that be public, then we would like you to send to the email so we can know and put you up on the website. Then the second ask is, like, just putting it on the website's not going to get us on the agenda. So you need to actually put it in the program planning survey. And to put it on the program planning survey, there are 2 different places. Each of them is a 300-word block. So if you only have this or maybe 1 or 2 others, you can probably fit them in the first block. Ours is 94 words because they ask you to say why you want it. And there's a couple of questions. I don't remember what they are. But this is the 94-word text box that if you can copy and paste that and put it into question 11. So when you get to question 9, you say, they say, do you have anything you want to ask? And you say yes. And they say, related to what? You say, this says social policy. This was made a few weeks ago. And I just brought to their attention it's actually in the representative democracy policy. So we need to change that. And then although we will give a heads up to the national organization that they should grab them from both. And then the box can take up to 300 words. And if you had a couple of different things that were already in that and going to take up too much space, you have a second option. You can put it in option B at question 16. And some of you, this is going to be really boring, but it can be tricky if you haven't done these before, that they can time out on you. And so the League of Women Voters does provide a PDF version so you can read it in advance and then write out your questions on a piece, on something in advance so that you can then copy and paste it all and get it done at once and not have it time out and make you so frustrated. If you if you're the right person and did not get a survey, or if you have other questions, this address down here is where you can reach out. But if it's more about what to do if you still can't fit all this in here, we have a member, Judy Esterquest, who was very active with the healthcare position that they got updating the concurrence that they used to update the healthcare position. And she's happy to take calls on that. So at the end of the meeting, I will go through and put a bunch of things in the chat. So if you want those, you can just wait until I have a chance to put those on there.
Betty, can you make sure you mention your deadline?
March, usually I do when I see that page. It's March 10th is the deadline for getting the survey in. And in my dreams, we would have the report up and you could read the report before that, but I don't know whether that's going to happen. Let me see here. Did somebody watch these well enough to see what questions have gone through that I didn't ask yet? Let me see here.
There really isn't any questions.
Okay.
There was comment.
So far, right?
Yeah. Okay.
So far.
It's, yeah. So it may take a minute to cogitate on this, but a lot of people are really confused about why are we going through the privatization position. I think I explained it better this time. I'm getting more practice at it. And then some people are confused about the privatization thing. And because we had more time on this presentation, because I've had to do some that were less than a half hour, that I hope that addressed it well for you. So the thing is that explanation is not in the position currently, in the LWV national position, in either the healthcare or the privatization position, it's not explained. But that will be in our report. And I'm thinking that we'll be advising that the Legal Women Voters include that in the write-up. Like the actual, when you look at these things, the actual position is in one place, and then I think it might be slightly indented so you can see it separate. And then they have it below that, like the history and, why did we change that, or when did the update happen, or, that sort of background information. And that might be a place to throw in the definition of like what we mean by privatization right there.
I do have one question that came in. They asked if you have a minute. Vermont passed a single payer plan. Pete Shumlin supported it in the end, but it failed. What happened?
So Vermont passed a bill, Act 48, that would allow us to proceed to a single payer bill if the governor submitted a budget that was passed. And then the governor did not win by as much as he had on previous elections. He felt like he didn't have the political capital to push this through. I don't know that I can explain it very well, but what I can clearly say, Vermont did not try a single payer system and fail. We didn't try it yet. We passed a bill to implement it, but it was never implemented. So it can't fail if it never was even tried. I do think that the issue of waivers could be helpful for other states who are looking at it. Governor Shumlin was confident that we did not need to bother applying for waivers, and I think that may have played a role in the affordability. He also was concerned about making a tax hike. And even though you can tell people, yeah, but your premiums are going down, even though your taxes are going up, for your wealthiest friends, your taxes will go up more than what you were spending on premiums before, because premiums are extremely regressive. The same premium at a business company, the CEO pays the same premium as the person who changes the coffee or whatever, So I think among his wealthier friends, he may have been getting some pushback too. I don't know. That's speculation. But he never submitted a budget for it. And there was a lot of anger. It blew the wind out of a lot of sails, and a lot of people just kind of like backed off of healthcare reform at the state level for sure, and decided to just focus on national. There was one group that persisted saying, well, let's try to get universal health care first. But it was hard to see how there were going to be any savings to be able to pay for the extra people. Like that's how you pay for single payer, is you cut out all the administrative crap. You save so much money that you will soon be able to cover everybody. And while you're figuring out the administration, it might be not immediate, but you will very soon be able to actually pay for all the care once you are not paying for all the administrative crap and the profit and everything.
There is another question that came up. They want to know how this may affect rural healthcare and the access issues there.
Well, we're the most rural state in the country. Okay, our biggest city has like 40,000 people, so we're very rural, and we're very concerned about rural hospital closures across the country. We feel blessed that although we have had some close calls, it's not been as desperate as in some other states where like many hospitals have closed. So if your hospitals are closing because for-profit companies are buying them up, this would clearly be helpful. If they're closing because nonprofits that are huge chains decide, well, we're losing money there more than some others, so if we close that, the people will drive to this other more profitable one. Well, that you could also be advocating against having huge chains do this. So, so there is a lot of ways that it could be helpful to rural areas. I mean, frankly, if the rural hospital is struggling so much that it was thinking about selling out to a for-profit hospital, it's probably in desperate financial straits. So your state is going to have to figure out, what are we going to do? You have to fix something somewhere. But this would help you have them not fix it in a bad way that's really bad for your infrastructure. Carolyn?
Betty, thank you so very much. This was the best that I think we have heard in a long, long time, and you put it together.
Well, Carolyn, you're part of the reason it's better. Thank you for your question earlier today.
Well, listen, I got a lot of comments, but just 2 pearls to throw in the dirt, okay? The first is, will you please make sure that your slides are available to each of us, because there was so much stuff there. It's going to take us a while and a couple of prayers to finish it. The second is, I think it would be extremely helpful to get out a clear memo to anybody who can read, to please read through the privatization position, and to read through, long though it is, odious though it may be, the healthcare one, because there are a lot of commonalities in that, and as you well know, there are a lot of things that we need to address in a very real way. I'll have some more questions that I have, but I'll just send those to you personally. But those are the 2 things that I think we really need to do for the public leaders and anybody else who wants to know. Thank you very much for this.
Well, thank you, Carolyn. I see Marilyn hand up.
Oh, another hand up. So go ahead, Marilyn, and then we have a question.
Yeah, it has a. We're seniors, and we got we have traditional Medicare, and we in January 21, we got our letter that said you have ACO Reach, and we didn't have any information whatsoever about this. So I just want you to know it is in Colorado. It's not just other places, and it really affects the senior population because they are privatizing Medicare. So we're both on traditional Medicare. I just want to make that comment because, and I just hope it was a good. You explained it well, Betty, and I'm glad we're having this session right now. Thank you.
Thank you. Thank you. Eduardo, I see a question in the chat about how many state and local leagues have embarked on this process for universal health care. I know that you won't know, but I also don't know as far as leagues. I could speak a little bit to state advocates that are not in the league. I don't know whether you know something about that, Eduardo, or should I field that one?
There are many people now advocating for Medicare for all in many states. There's a network of people that I'm familiar with for a long time. But I just wanted to mention something for you. Medicare has been privatized for decades now. What we are seeing now is advanced stage of privatization. It's basically quite the opposite. The traditional Medicare has become the smaller program compared to Medicare Advantage. So this is an advanced stage. But if you look at the history of Medicare, this started in the 60s. From the beginning, Medicare opened space for the private sector to actually deliver a lot of the service and insurance companies to do it. It took decades for them to become as big as they are now. We are actually running against the stream because this train left the station at least 30 years ago. So we have a long journey ahead of us to deprivatize, which is actually what we're talking about. The only way to make Medicare for all viable is if we stop the privatization, which is now in an advanced stage, meaning that many for-profit corporations are coming to Medicare quickly now because there's a lot of money to be made. Medicare is a very, very big program. And that's why they're coming, because if Medicare didn't have a lot of money to be made, they wouldn't come. And they're coming from different directions, in the management side, in the delivery side, in private equity, So there are a lot of attacks on Medicare from different angles. And for us to understand this correctly, we have to look at the different angles. Because now what they're doing is they're buying hospitals, selling the land. They don't care about the hospital. They want to make money off the land. They get loans after they buy the hospital, and they make money off the loan. It's just a financial system. That's what's happening. So that's what private equity is all about. So really, if we don't stop this process within the last decade or so, we're going to see in the future that seniors will be completely in the hands of the private sector. So that's what I believe this is so important for us to move. And actually, we are late already in the game, unfortunately, and we have to move fast because they're moving very fast.
Are there any more questions from the group?
So I see a question in the chat,
Okay.
or a comment. Carol Mattoon said we could substitute the word privatization with profitization so people understand. So I don't know that profitization is a word, but even if we thought that corporatization or something would be a better word, profiteering, plundering, but we can't actually change any words in a position. Once a position has been voted on and you say you want that for the concurrence, then, somebody can create a different position and promote that. But we can't change the position on the floor at the convention to a different word. And we can't actually. I would like it if I could negotiate with the National League on what would it take for you to recommend us on the how would we need to word this for you to recommend us? But that isn't something that can really happen either. Let me see what else we have here.
She did clarify her comment about profitization, just not in the legit, the actual position piece, but just when you're explaining it to people, it does make sense to me.
Okay, thank you. Right, so Bill says that fortunately PNHP was able to stop the ACO changes. Actually, we were able to stop the direct contracting entities. This was back in 21, I think. That the DCEs, these direct contracting entities, were getting such bad publicity from the Physicians for National Health program that they said, "Oh, okay, we'll stop. We won't let any more contracts happen after December 31st of 22, and starting January 1st of 2023, it'll be this brand new great equity thing called ACO Reach." And then you look it over, and it's actually quite similar, except they get more money if they put Black people on their list or something like that. I mean, they don't actually have to show that they have better outcomes. So yeah. But these ACOs are continuing. They're just and now they're changing to an ahead program that I need to research. I'm not sure what that one's going to be.
There's a request that you post relevant web connections.
So I think I have a paper here that I can copy and paste, but Zoom doesn't let you do too many at once. So let me do a couple and see if they let me do that.
While Betty's doing that, are there any other questions or comments? Oh, somebody's working on. Okay.
See if that. Oh, yeah, it went through. Okay, we'll try another.
Yep.
There's a number of them here.
For all the league members in attendance, do the technical steps make sense to everyone? If you believe that this is an important thing to bring to the national convention, you understand how to go about doing it? It is sort of technical, but I guess that's the way things are. Okay.
So a lot of these things you can get to them from several different directions, so it's kind of repetitive. but I'm just throwing all the stuff that I had asked Candy to put in when we were doing the meeting on Monday night. And so she was doing some of them throughout the meeting, so it may be a little repetitive. Okay. So yeah. How many of you are the person who actually fills out the survey?
Not yet.
Yeah.
So you may be explaining to your president how important it is that you use, that you copy and paste and that use that actual wording. You should definitely reach out to your president and see whether they got the link to the survey, because I just heard today from somebody who says, oh yeah, we'd like to support you, but we didn't actually get a survey. So how do I get one? I see John has a question.
No, not a question, just a wonderful presentation, Betty. Anybody that's got any questions, go to the toolkit. That's the place to start. And at the top of the toolkit is the band, and it goes straight to everything Betty just referred to. So start with the toolkit, which is Barbara's baby.
I like how the League of Women Voters Port Manhasset, Washington, or it's at Port Washington, Manhasset, did the healthcare website that last year, 2 years ago, that it's actually only on one page. And if you click on a link, it'll take you to the right place on the page. But if you're down lower and you say, now, where were the pros and cons? You don't have to figure out what different page it was. You can just scroll up higher or lower. So I'll be checking with Barbara about whether that's something that we can do as it gets busier, when we get the report on there too, and get our pros and cons. And like right now, that first concurrence page, I think, could be organized a little bit better. But the one about what to do, that one's very well organized. The pages, the actual document, the steps of what to do, but also the page that has those, like the sample message on it and stuff. You can find stuff. So this link has all the good stuff, right? I don't know. Let me see. Okay. Yes, that's a shorter URL for the same thing. I find it pretty easy to type in, like LWV healthcare reform, except I have to make sure I don't go reform instead of reform. But any other questions?
I don't see any more. Any final comments or questions from anyone at all?
Missed because it was between a few others. Another question that came up in our chapter was if we're looking at promoting less privatization. Hold on, it got moved. Maybe I'll just expand my screen.
Oh, I see it in between when I was popping all those things on.
Yeah. Okay, thank you. I'm having a hard time moving my scroll bar, and Norma has a question as well.
So
there we go. Will there be checks and balances? That's the question.
So in our position at the top, I think you'll recall that we talk about, let me see here. I can share the screen again. And is that it? We'll see in a minute. Yes. Okay. So at the very first paragraph, quality, transparency, accountability, and affordability are critically necessary for effective administration. Further, the League supports public oversight of all aspects of healthcare, from policymaking to administration to accountability, and public participation in policymaking and accountability as essential. So that is the key part for making sure that that you hold your public programs accountable as well. And we were very careful with that language. At first, we had it public oversight of everything to policy making, from policy making to administration. Let me see here. We had public oversight and participation in everything from policy making to administration to accountability. And we were like, so what would it actually look like to have public participation in the administration, like the public oversight we could get. So we split it up a little bit to just make it be very clear. So for instance, from that Act 48 that was supposed to get us towards single payer, it did create the Green Mountain Care Board that is responsible for regulating our insurance companies and approving the budgets for our hospitals and things like that. And they are a public board in that they have to hold public meetings. If more than two of them are meeting together, they have to warn it as a public meeting. They can't just socialize it for coffee over lunch. But right now, a bill that is getting a lot of attention that we as league members are able to actually, because of our new position, can be involved in that. This would change the oversight for our monopoly that's trying to take over all the rural hospitals. This is our UVM, and they already own four of them. Is it four in Vermont and one in New York, or maybe it's four total, three here and one in New York, across the river in Plattsburgh. And they are not cash strapped, and the rural hospitals are. And by letting them have more control and they have more market share, it makes it harder to hold them accountable, because they're a private nonprofit, hold them accountable for like how much of their money is going to high paid executives instead of to our nursing staff when we have a nursing shortage, and how much of the resources are being poured into the highly remunerative surgeries instead of into the substance use disorder centers in the rural hospitals that are desperately needing that kind of care for locals. So if you have a chain, they can direct like where to send the money to buff up their services. They may choose to put it in places that are actually not in need of it as much as some other places. So you really want to figure out, how do you do your accountability? Even if they're nonprofit chains, how do they decide where the resources go? And how do you hold them accountable? I will stop sharing now. Did that answer that question well enough?
Norma, do you still have a question?
I just have a comment. What got me really interested in attending this session was I had a hip replacement surgery this past year at Littleton Hospital, and I didn't have family to take care of me. I don't have children or grandchildren. I've got family in town, but they weren't able to take care of me. I mean, they're older too and have their own issues. And so I was able to talk my way into letting them let me stay in Littleton Hospital for 4.5 days because I had no one to take care of me. And as time went on and I got my EOB, my explanation of benefits, I have United Healthcare Medicare Advantage, which I got kind of bamboozled into signing up for. And it looks to me like that United Healthcare only reimbursed Littleton Hospital for about 19% of the cost. And so I assume that means they paid for 1 day, and this is not sustainable.
So I'm going to actually share that it's very hard to know what to make out of a bill from a hospital.
Mm-hmm.
So a hospital makes enough money on Medicare to cover its costs. They may complain a lot, but the thing is that if they got Medicare from everybody and didn't have their extra administrative fees because they have to bill so many different companies, et cetera, they could have smaller billing staff and all, and not have the delays on payment from the insurance companies that try to delay on the payments. But anyway, if they all got paid on Medicare, they would survive. It's like having non-pays that also makes a problem. Except maybe the smallest hospitals that just don't have enough volume, then they might still not. But for the larger hospitals, Medicare pays enough. So when you say Littleton, is that Littleton, Colorado?
Yes.
Okay, because right across the river is Littleton, New Hampshire. I was going to say. So I recently got the bill for my routine mammogram, and it said $1,000 on it, and Medicare reimbursed I think it was $100 to the facility doing it and $200 to the doctor reading it. But like, why do they even bother billing $1,000? Because you know that no commercial insurance is paying them $1,000 for that if Medicare is not. They're not doing that. They make up these numbers so they can say they give you a discount. So depending on, it may be that they denied paying charges. That Medicare Advantage may well have denied paying for those extra days. And that is something that we really need to address. People, you can't send somebody home if there's nobody to take care of them. Oh my gosh, So we need to figure this out. Now, people do actually often have better outcomes if they're at home through some illnesses or going home sooner, but they have to have the supports. If they don't have the supports, you can't send them home,
Yeah.
So, so these are big problems.
Well, a friend of mine is a nurse, and she's retired, but she's worked in all aspects of nursing. And she did tell me before I went in for surgery that it's illegal to send me home after a major surgery if there's no one to take care of me. So that helped me to advocate for myself.
Yeah, not all states have that protection, so that's good.
Yeah.
Well, we're past time. Are there any final questions or comments before we wrap up? All right.
The comment I would just make is Bill had asked about how many state and local leagues. Does anybody else know how you can find out what local leagues are working on? Is there like any compilation anywhere?
If anybody knows, it's Barbara.
But there could be leagues that just don't bother telling her. So across the country, there are a lot of states where there are advocates who are finding state legislators to sponsor something. And sometimes it's an enthusiastic sponsor, and sometimes they're like, okay, and sometimes they just can't get a sponsor. And sometimes they get a sponsor who wouldn't actually vote for it if it ever made it off the wall, but they figure they're safe saying, yes, I'll sponsor it because it's going to just sit on the wall and nobody's going to take it up. But there are a lot of hopeful people, and there's a lot of different strategies people try, whether you're looking at doing just the single payer, the universal primary care, or whether you start with just hospital, which has the drawback that if you have free hospital care, people will skip the primary care and go there if they have no money. And then you'll have, inappropriate utilization of the hospitals, which would cost a whole lot. So that's not necessarily a great way to go. Another idea could be to start with formularies, maybe, the pharmaceutical industry having a single place. I haven't heard anybody doing that yet. I'm just bringing it up in my own state. Another interesting one is New Jersey has gotten a couple of sponsors that the bill basically, and I haven't read their most recent update on it for this legislative session, but what it was last year was our legislature is if they pass this bill, that the New Jersey legislature or governor or somebody is supposed to ask CMS, this is our number of population, tell us how much we owe you if you put everybody on Medicare for us, and we will pay you. I think it's a great idea. What are the chances of it getting anywhere?
Well, our Colorado League has been working very hard, along with a vast coalition, to put a bill, through all the way to the governor's desk this session, to have a study for the School of Public Health to do a study and analyze the efficacy and financial situation, how it would all come about if we could have a single payer system in the state of Colorado. So as I have done in the past in these meetings, we are a task force, and so I like to think about what tasks we can all give ourselves, and obviously Betty has given us a big one to go back to our local and state leagues and advocate for the Vermont position to be on the agenda in the national convention in June. So I'm hoping that this presentation has given everybody that information and enthusiasm to do that.
Thank you so much. Thank you so much for hosting.
Sure.
And thank you for your attention. I know it's a good chunk out of your evening, so thank you much. And I hope that
Sweet dreams over there in Vermont.
thank you. And I hope that you will be inspired to want to at least have a discussion. Thank you.
Absolutely. Okay, everyone. Thank you for attending, and we'll see you next month. Take care.